Welcome everyone to our LinkedIn live panel discussion, Understanding Suicide Prevention, Community, Signs, and Support. I'm Silvia Kaminsky, AAMFT Board President, and your moderator for today's important conversation. We're thankful to have so many of you today for tuning in for this very vital conversation on suicide prevention. Please feel free to leave your questions in the comments section as we go along. I will address as many as we can during a Q&A session. Remember, this session is being recorded for those of you who may want to view it later. So let's get started. Joining us today are three distinguished experts in the field of mental health and suicide prevention. First, we have Dr. Lisa M. Horowitz, staff scientist at the National Institute of Mental Health, who has focused significantly on the early detection of suicide risks in medical settings. Dr. Marie-Natalie Baudouin, a clinical psychologist and AAMFT professional member who has been profoundly involved in empowering clients through innovative therapeutic approaches. And finally, Dr. Kat Hertlein, a leader in couple and family therapy and also an AAMFT professional member, currently serving as the Associate Dean for Faculty Affairs and Professional Development at Wright State University. Welcome to all of you, and my sincere thank you for taking the time to address this important topic. All right, so let's begin with Dr. Horowitz. The recent findings on suicide rates amongst children, especially the increases among girls, preteens, and certain demographics are very alarming. Could you share with us the key data and why early screening is so vital?
Well, first, thank you for inviting me and thank you for highlighting this such a critical public health problem of suicide. And so suicide is the second reason why young people die. And so, right, young people aren't supposed to die. They're supposed to grow up and live long, healthy lives. But if you look at the number of youth deaths from 2021, almost 20% of youth deaths were from something that's potentially preventable, suicide. So those are staggering numbers. You can imagine if 20% of deaths were from an infectious disease or some other cause, there'd be fixes and public, health approaches. So we need that for suicide as well. But while these statistics are sobering, there's so much action we can take. And it really starts with early detection. So my research team focuses on giving healthcare providers suicide risk screening tools so they can feasibly detect kids at risk and then get them the help they need. And so why did we pick the healthcare setting, the medical setting? And if you look at death registry studies, what you find is that people who died from suicide, and not just adults, but young people too, have visited a healthcare provider, maybe a mental health healthcare provider, maybe a medical healthcare provider, months, sometimes in the week before they die. But the problem is they don't walk into a doctor's office and say, I'm thinking of killing myself. So if someone doesn't ask them directly, are you thinking of killing yourself? They most likely won't speak about it. So the majority of suicide attempters go unrecognized because the majority of settings don't screen. So we created some suicide risk screening tools where we have one called the ASQ, the Ask. It takes 20 seconds, it's 4 questions. And you can detect if someone needs further assessment. So these are tools that help healthcare providers start very awkward but very critical conversations, because these are really important conversations to have, especially with young people.
Thank you, Dr. Horowitz. You've mentioned the need for early screening. What barriers currently exist in implementing these screenings in both schools and medical settings, and how can these be overcome?
Sure. So obviously healthcare providers are very busy, and so they're doing a lot of other things. And so often time is a barrier, training is a barrier. A lot of people, even mental health clinicians, you would be surprised, are not necessarily trained to detect and manage suicide risk. And it's a scary topic. People feel awkward talking about it. But the problem is that kids who are thinking about suicide are thinking about it, whether or not you're going to ask them about it or not. If they're thinking about it, they're thinking about it. So asking about suicide risk with an evidence-based tool, and if you use something like the ASK, and we made the ASK part of a clinical pathway. So it's 3 tiers. You give the screening tool, and then if someone screens positive, you give a brief suicide safety assessment. And then that helps you determine, do they need a full mental health evaluation, or do they need to go to the emergency department? Most people who screen positive on a suicide risk screening tool do not need the emergency room. That's a lot of times an overreaction. And also, you might be the first person asking this young person about suicide, and they tell you, and then you send them to the emergency room and they get put in a paper gown and all their stuff is taken away, and they're given a very costly security guard, and then they're sorry they told you. So there's a very patient-centered, compassionate way to manage suicide risk. You brace for that non-no answer, you listen, and you give them further assessment. You see how at risk are they right now, but you're also just listening and giving them a chance to talk about what's probably very disturbing thoughts in their head.
Thank you. And given the diverse increases across different racial groups, how can mental health professionals tailor their approaches to better meet the needs of these varied communications?
Right. So when we look at the suicide rates and we see them going up, they don't, there's many disparities, right? So American Indians, Alaska Natives, they have the highest rate of suicide than any other race or ethnicity. Black youth have the steepest increase right now in suicidal behavior, so much so that the Congressional Black Caucus convened an emergency panel and put out something called the Ring the Alarm Report, which calls for more interventions, more research on youth suicide. Hispanic preteens have a steep increase in suicide risk. So universal screening can bring health equity, because you're not picking out, oh, I'm gonna ask you about suicide risk, but I'm not gonna ask you. So screening everybody, and the AAP right now is recommending age 12 and over that you screen for suicide risk. That can bring health equity. And it's really important that you're culturally sensitive to both, not only talking about suicide, but the interventions. So, and that's, it's not a one size fits all. So it's hard to just give a formula like this is, you wouldn't want to say, okay, you're white youth, so we're going to do this. You're Black youth, so we're going to do this. You're Asian youth. Like, it doesn't work like that. You have to figure out what the cultural sensitivities are and be responsive to each.
Thank you. That's,
yes.
Yeah, that's critical. I'm in Miami. It's a very diverse community, so I completely understand, the importance of what you just shared with all of us. Let's move on to Dr. Boudouin. From your experience, how do family dynamics contribute to or help mitigate the risk of suicide among family members?
Yes, family dynamics can have very important roles in preventing or mitigating suicide risk. And we also have to remember that the families are embedded in a sociocultural context. So, I always like to remind people that, it's not so helpful to blame families, because they're also affected by social media, and their children are affected by peers and by school culture and friends and all of that. But that being said, families can play a significant role, in a sense that they can not only provide a supportive environment, with safety and good communication and the flexibility for young people to become the person that they want to be, but also I think one of the aspect that we often forget is that families kind of set the tone for children's worldviews and for children's views of life, like that life is made with ups and downs, and that we all have moments of hardship, and we push through and we get to the other side. Family can also shape children's views of problems, like problems are something that we can address, and here's how we're going to address it. And families shape also how we cultivate wellness. When we're feeling down, what is it that we can do to feel better? What are the sources of happiness? So families shape a lot of the foundational backbone, so to speak, or the foundational layout of how we approach any situation in life. And also, I mean, there's a lot that could be said here, but I'll also add that families have a profound effect on how children see themselves as being skilled and competent and capable of overcoming things. So, for example, when children are facing a struggle, it could be a little struggle, and parents are able to say, yeah, this is tough, but I've seen you overcome things like this before. You'll be able to push through. Then children kind of grow up with having this self-confidence to overcome many different things. And I'm reminded here of an example of a little boy that I supervised the clinical work with last year, who felt, he was 10 years old, and he felt so overwhelmed by the amount of homework that he was behind, that he was, contemplating suicide. And he had planned to eat the rat poison that he had seen at home and all of that. Mm-hmm. And in this little boy's worldview, if there was a problem and he felt really stuck, there was not that many options, right? He hadn't grown up with the idea that, well, when there's a big problem and big feelings, you can talk to someone about it. And when you talk to someone about it, then we find solutions, So that's just kind of an example of how this general philosophy of life that families put in place can have a really big effect in mitigating or contributing to suicide.
Marie Natalie, you've already begun to address my second question, which has to do with specific therapeutic interventions, and I'm wondering if you can share more that are effective in strengthening family resilience against challenges.
Mm-hmm. Yeah, there's really many clinical practices that can be used to strengthen family resilience. In a first session with a family, I'd really be interested in highlighting people's intentions and their effects, right? Because oftentimes parents have such good intentions. Mm-hmm. They really, care for their young people. And even I found, parents who sometimes have abusive behaviors towards children, they do so because first, it may be the only way that they know to handle a problem behavior, right, but also they really hope their child will, learn something. So when you contrast intentions and effect, if I can ask a parent, what was your intention when you did that? And the parent might clearly articulate, well, I really wanted my young person to realize how important it is and how I love them and, how I really want the best for them. And then we look at the effects, well, let's see what that did to your child. Did that empower them? Did that make them closer to you? Did that move them away from the high-risk behavior? Or did that make them feel disempowered and even more likely to engage in the problem behavior? And so by contrasting intentions and effects, we're able to make visible a lot of parenting practices that are helpful. And then we can connect those in a pattern of interaction, right? So the more a parent does this, the more it pushes the child away. And the more the child is pushed away, oftentimes, the more the parent will use the same parenting technique. So, and then we also look at cycles of care, of course, what it is that brings parents and children together as a team, and better understanding each other and being able to listen and support one another. And that also applies with young people who have attempted suicide or who are self-cutting. We can examine how the patterns of interaction around when self-cutting behaviors happen or attempts happen, and what is the support that parents or even teachers at school can provide that will be most helpful for them in, moving away from this habitual ways of behaving.
Marie Natalie, I really like the way you approach this very scary problem area for family with such love. I really appreciate, the way you speak of, how we can speak to families in a way that's helpful, rather than, accentuate the alarm that they already feel.
Mm-hmm.
Yeah. So in your Family Therapy Magazine article, which we are including a link to, by the way, in the comments, you discuss empowering individuals considering suicide. Can you explain how empowering individuals can shift the traditional approach to suicide prevention and what outcomes you've observed?
Yes, definitely. I think sometimes the traditional approach to suicide assessment can be very disempowering for young people because it kind of focuses on one stream of thought. Human beings have many different streams of thoughts, that can coexist at the same time. To take another example, when people experience grief, they might have, the sadness for the loss, but they might also experience relief that the person is no longer suffering. They might, experience joy at reconnecting with other family members. And all of those streams of thoughts and experiences coexist. And so when we're talking to a young person who's contemplating suicide, we can linguistically reflect that we know there's a whole lot more to them than this suicidal ideation, right? They are so much bigger than that, and their lives are so much richer than that. And we can do so by externalizing problems, which is a narrative practice developed by Michael White and David Epstein. So if you talk, for example, about how sadness or overwhelm or despair is getting the young person to think about ending their lives, you can also ask if there's a part of them that doesn't want to end their lives. And, I would say 99.9% of the time, people will say, yeah, there's a big part of me that doesn't want to end my life, and you can ask them to put a number on it. They might say 90% of me doesn't want to die. And so then that gives you the possibility of examining what is it that this other part of them is reminding them of, like what is it that that part of you is telling you at that moment where you're having a plan and you're thinking of doing it. What is this part of you telling you in terms of your dreams or your hopes or the people that you're leaving behind? And how many times does this part of you help you not do the gesture? And that's a really, really important question, because ultimately we can get the young person to put a number on it. So for example, if the young person has been contemplating suicide, say for the last 10 months, and I'll even ask them, well, how many times per week, did this sadness make you think of killing yourself? And they might say, 10 times per week. And so then you would calculate, okay, 10 times per week, there's 4 weeks in a month, that's 40, 10 months, that's 400 times. And so you put a number on it and you ask the person, so sadness made you think of killing yourself 400 times. And all 400 times you were able to control that impulse. What do you think about that? That that part of you is stronger. The part of you that wants to live is stronger than the part of you that wants to die. And let's examine how you've done that in more details and who has supported you in overcoming this impulse. And by doing that, I'm not only using an area of practice, but I'm also kind of tapping in a lot of the brain science, right? The interpersonal neurobiology that reminds us that the more we give attention to a behavior or a thought pattern or a feeling, the more we talk about it and share about it and explore it and expand on it, the stronger it becomes in our brain. And then it becomes more readily usable by the young person. And so at the end of a conversation like that, young people are so empowered. I've seen it countless of times where people are empowered to take actions and hopeful that they can overcome this thought and more confident in themselves, because sometimes I encounter young people who are scared of themselves because they don't want to die, but they've been hospitalized many times and they're scared of themselves. So it really builds confidence and hopefulness.
Thank you, Marie Natalie. That was such a powerful example of an empowering approach and strategy. Thank you very much. And finally, Dr. Hartline, considering your extensive background in couple and family therapy, how critical are community support systems in enhancing the efficacy of suicide prevention strategies?
I think they're very important. And I think it also means that we have to take a broad view of what community is. Quite often, when we think about what a community-based prevention mechanism would be, we think about gatekeepers, and they are important to reducing that suicidality, or to at least identifying when it's happening in some place and time with an individual. Okay. And when I think about the role of gatekeepers, or when I talk about gatekeepers, I'm talking about people who are really identified to be in particular systems, to be able to have accessibility to people who might be engaging in suicidality or having some suicidal ideation. They can identify, they can assist with the interventions, they can get people connected to the resources that they need, and they have the ability to have support themselves to be able to go through that process. Typically, that's where what we think about when we think about that community of interest. But there are more ways to define community. So, for example, a community response might be something like strengthening economic supports in the community. So and the extent to which that will remediate or address suicide and try to bring it down in the community, I think is still yet to be seen. We're still trying to understand what the effects of that would be, but that is one strategy. Another type of community support or community resource would be creating a protective environment. And that might be kind of in an individual perspective, like removing some of the things that are lethal within one's individual home, but then also thinking about installing barriers or fences at places that might be jump sites or suicide hotspots, right? Or curtailing the purchasing of particular materials to be able to create something that might be really destructive. Another thought about creating that protective environment is working in organizations that have policies and strategies that are going to be able to impact the feeling of people in a positive way and construct a culture where suicide is something that is addressed, investigated, and gets people connected to the resources, such as in police work and in military settings. Some of those policies create a lot of support. Other community support mechanisms would be anything in the realm of social and emotional learning. So it might be programs in high school, programs in middle schools that are teaching people coping skills and problem solving skills to be able to identify what people might need help and refer them in a particular way, or to even get other people who are saying, hey, I'm feeling okay, but after that training we had today, I'm noticing something about my friend, and kind of getting people to gatekeep in that manner. And then finally, looking at what might be the support structures that we have for specific people at risk. So once we have people who are in risky situations, can our community respond? Are there crisis lines available? Are there crisis phones, for example, on non-pedestrian bridges? Are there public awareness campaigns and educational campaigns that are really going to help from a community perspective be able to address that need?
Thank you. That is such an important perspective for us systemic practitioners to keep in mind in terms of the wider, realms of support for our families. What are some practical communication strategies that therapists can use to effectively identify and address suicide risks amongst their clients?
That's such a great question. I really appreciate what the panel has said thus far, and I would put big exclamation marks besides those strategies. I think they were fantastic. But sometimes in those one-on-one sessions, you come to some information where your spidey sense goes off and you think, I might need to ask something different. Okay. So a couple things that we know from what are some of the warning signs of suicide, common ones you've already heard. If people are talking about suicide to others, if they're hiding their suicide wishes, if they're engaging in some reckless behavior, if you notice their mood changes, if they're withdrawing, and those things you may be able to ask directly. But we have a lot of clients who are very savvy. And when you start hitting those questions, they might know exactly where you're going, right? And maybe prepare a response that's going to lead you away from it. Another thing that's important to know about therapists, and this comes from research that has just looked at psychotherapy in general, but therapists aren't exactly great at understanding when a case starts to deteriorate. They're often not good. They're not reliable at noticing. They might notice symptom worsening, but absent of a symptom worsening, how do you know that that goals aren't being met or that the client is deteriorating in some way? So we have to think about not just those suicidal warning signs, but what's happening in terms of their compliance with treatment. Have they skipped a few sessions here and there? You might want to have a conversation about that. Another thing that we know, clients, during that 1 to 5 session early on in treatment, we're not thinking about whether the client is necessarily deteriorating. And that stage, we're thinking about what our assessment is. Once we get into therapy, we sort of forget about the assessment piece and are doing sort of business as usual. So when you're having these conversations with clients about whether they're deteriorating, whether their symptoms are coming back, the literature suggests that you actually keep some piece of that assessment going through each of the sessions so you don't miss some of that deterioration. You might go back to some of your common questions. Tell me about your level of depression. Tell me about if there's anything that happened that really set you off. How's your school functioning going? How's your job functioning? What do you notice about your motivation? I know you said it was, at this level when I did our initial assessment. But what are you noticing about it now? Have you noticed the client contact you, or have you noticed them not contact you as much as they used to? You might want to inquire about that because that reflects a change. Is there something that changed in terms of the modality of treatment? Have you asked enough about, do you feel like you have adequate social support, or has your support changed since we talked last week or 2 weeks ago? Continue that information gathering every session instead of just kind of doing the 1 to 5 and sort of moving along with treatment as usual.
That ongoing assessment piece is so important, Dr. Harlan. Thank you for emphasizing that. Could you discuss how technology and our online platforms can be leveraged to support communities, especially in remote and underserved areas?
This is such an important question. And it gave me, as we were thinking about some of the questions, it gave me a bit of a mind cramp, because when I think about technology and suicide, most of my work is in the area of young people. And I think about the displacement of in-person social interaction, kind of at that individual level that really is a precursor to levels of depression and stress for young people, which can lead to higher suicidal ideation. The fact that they're not getting enough sleep, the fact that we have the displacement of the in-person social interactions in a generational level, not just kind of in the individual space, but this is the way our young people are living and working and operating. And these young people who are now in this generation of having social interactions online and not necessarily in person, are also going to be the people who are going to be in charge of the community prevention programs and be part of the gatekeeping that we need to have to be able to make sure that we're connecting people to resources. Okay. So we have to teach our gatekeepers to be able to accomplish that role in a way that is consistent with their generation, which is using the technology and the resource available, but also not in a way that's going to continue to socially connect us. Okay. So one of the things in terms of prevention is the gatekeepers and the community have to have the knowledge, skills, and support need. People need to know where to access the resources, how to get people connected to the resources. They have to be able to use the trainings that are available. We've got to be able to put trainings online to increase that accessibility for the gatekeepers and the people who have interests in the broader community and who are able to get people connected. We need to improve our communication systems. A part of that is even when you're working in an institution, like for example, I work at the Boonshoff School of Medicine, and we ask people to use their university email, but a vast majority of our practitioners don't, and that's okay. They use a different email system, but it means that when I'm giving information, we're leaving out lots of the population who are actually working with people who are engaged in these risk factors and these crisis calls. Okay. So other things that also have to happen in terms of technology and the community is making sure that the gatekeepers and the community responsible have ways to be able to support each other. We're asking people, if they've got that suicidal ideation, to get connected to their support systems. When suicide happens, we're asking people to get connected to your support systems. And when we're doing gatekeeping, we need to make sure that people are connected to their gatekeeping support system, because you alone cannot overcome some of the inequities that are entrenched in our systems.
Thank you, Dr. Hartline. Next, I would like to take about 10 minutes, which might be difficult. You all, there's been such great information, and you all sharing so many good ideas. But I'd like to take about 10 minutes to have an open discussion amongst the four of us, the three of you primarily, on integrating these insights into a comprehensive approach to suicide prevention. How do we balance individual, community, and policy level interventions? So how about we start in reverse order, and I call on you first, Dr.
Yes, Dr. Hartline. Yeah. So I think it becomes really, really important to make sure that we as a community are coming together and we understand what the community is doing at each level. So for example, when we think about what's happening at an individual level, how do we as community individuals need to address the individual need? We need to, do something different with kids in terms of managing their depression, kids, young people, anyone really, in terms of managing their depression, managing their self-harm. What are some of the mechanisms that we have to be able to address that in a meaningful way? A second piece is looking at how do we, as kind of a bit more of a micro community, kind of a social environment, what's happening in terms of the schools, where people are operating in terms of their systems. How do we get people connected to their resources, to their gatekeepers, in a way that is going to inspire confidence, and in a way that is going to lead people to know that this is a community of support, not a community of guilt, shame, and punishment, as we're building out a lot of those policies. Another piece then is to look at, from then the larger perspective, how do we inform policy to be able to create either technologies or to put resources into the places to make those communities more safe and to maybe enhance some of those protective measures in lots of different ways, whether that is decreasing the lethality in some areas or increasing the number of gatekeepers or the quality of the gatekeeping. Each of those things has to happen at these different systemic levels. I think of Bronfenbrenner and the ecological model. What can we do at each of those stages? And everybody has a responsibility.
Thank you, Dr. Hartline. I appreciate that. Dr. Baudouin.
Yes, I agree a lot with what you said, Catherine, in terms of having, a whole community response and gatekeepers involved in many different areas. Given that I work a lot with schools, I collaborate and supervise a lot of the services in schools. I find that schools can be such an important place where intervention can take place, because then we see children from all walks of life, and from really impoverished neighborhoods to very privileged neighborhoods. There's possibilities there of offering individual services to children one-on-one, so that we can really address the unique situation of their life. But there's also possibilities of addressing the community, either going through classrooms and doing classroom projects. And I'm not just talking about classroom projects where we teach kids something, right? Which again becomes like top-down teaching. Here's something that you have to remember. You have to remember to use I statements or all of that. I mean, that can be helpful. But I think in the classroom projects, we can also help children feel competent. And in the classroom projects that we facilitate at SCIPS, we like to go in the classroom and ask young people of all ages what they have done. What have you done to overcome anxiety? Or what have you done to overcome the overwhelm? And have them share strategies and stories with their classmates, so that not only are they sharing ideas that are age appropriate, but also it gets young people to see each other in a different light, especially if you have children sharing that they were maybe really annoyed or angry at lunch because a situation happened, but they chose to walk away. They chose to keep the problem small and walk away. And so highlighting everybody's effort in a classroom not only changes the dynamic between them, but also empowers each young person to feel more confident. And also in schools, there's some, great school districts who have wellness centers, where if a young person is feeling dysregulated in the classroom, or, has had a big event at home that morning and is unable to concentrate, they can step out of the classroom and go to the wellness center to reset, or to talk to someone for 15 minutes, or go in a little tent there. Sometimes they have a little tent where young people can just, isolate for a few minutes and reset, or there's fidgets, or there's all sorts of things, sensory things that they can do to reset their emotion regulation before going back to class. And there's also leadership programs, of course, in schools, where then you train young people to be on the lookout to help other young people of different ages. And so all of these community responses can have a huge impact on the likelihood that a young person will speak up when they need help and they're having big struggle, and also the likelihood that they will be noticed by others as struggling. So, yeah.
Thank you, Marie Natalie. I think I'm going to stick to first names.
Yes.
Sorry about that, Kat. So I'll go on to Lisa, last but not least.
Sure. I mean, I really appreciate what the other panelists are saying, and you're really talking about fostering resilience in this multi-pronged approach way, which is how you attack public health problems, right? And so fostering resilience in the community, or fostering resilience in the school, and fostering resilience in the medical setting and the mental health setting. And so how do we make sure that families and parents feel comfortable talking about suicide risk with their kids in the same way we want them to talk about drugs and alcohol and safe sex? How do we prepare them? So the biggest myth about suicide is that if you ask someone about suicide, you're going to put the idea into their head. And there's at least 4 research studies that debunk the myth. And in fact, it's shown that's the opposite, right? The best way to keep someone safe is to ask them directly, are you thinking of killing yourself? And then really listen to the answer. So I think being able to have early detection through evidence-based suicide risk screening tools is really important for the healthcare setting. And then giving busy healthcare providers feasible ways to manage patients that screen positive, so that everyone's not sent to the emergency department because that's not good for the patients. It's not good for the providers. And then something else I'm seeing more than ever now is healthcare providers also being triggered by screening for suicide risk. And so we have to take care of the healthcare providers too. We can't just train people to do the screening. We also have to give healthcare providers support for, you know, what I can't tell you how many trainings I've done where people who are being trained are actually also at risk and need help and support. So it's really this multi-pronged approach that I think everybody's talking about. It's not suicide's not a one cause phenomenon. It doesn't have a one size fits all approach. And so I really appreciate that you got people from all different perspectives to really take on such a big public health problem.
Thank you so much, Lisa, and thank you all for your thoughts and insights. Now let's move on to our audience questions.
Sure.
It looks like I'm having some technical issue with getting the audience questions. So if
Can I?
okay, thank you. Thank you. That works. Perfect. This is for Lisa. If someone screens positive for suicide risk, what are the 3 steps to take right away?
Sure. So first of all, there's a difference between screening and assessment. Screening is a very rapid way to identify someone that needs further assessment. You don't diagnose or do a disposition from a screening. So you need to do a brief suicide safety assessment. And if for some reason you don't have more mental health access or resources, you want to make sure you do a safety plan, right? So that's what are you going to do if it's 2 o'clock in the morning and you're thinking of killing yourself? You want to do lethal means safety counseling because it's so important when someone's in a suicidal state that they don't have access to firearms or pills. Sometimes parents don't realize how many medications they have in their medicine cabinet. And then you want to give everyone 988. And a lot of people don't know about 988, but that's the mental health emergency line. So that's access to the 24/7 trained people, suicide lifeline, crisis text line for kids. That's such a great resource. Every kid should have that in their phone. You text 741 741 and there's always somebody to talk to. So there's always something to do when someone screens positive for suicide risk. But what you don't want to do is just have a reflex of sending them right to the emergency room.
Thank you, Lisa. The next question is for Marie Natalie. Schools are where children spend most of their time. How can we teach children to recognize another child who may be thinking about suicide? And how can we teach them to speak up about this?
Yeah, I mean, that taps into community, right? Like when children feel well connected in the community and pay attention to others, then they're more likely to notice that a friend is in distress, and more likely to also tell an adult that a friend is in distress. So having some personnel on site that is available, if a student feels that their friend is at risk or has been noticed as self-harming, that they can go talk to this adult is important, and that they will be welcomed and not judged or not turned away is really important. But also, I think certainly the work that we try to do at SCIPS is to create communities of belonging in the classroom, where children get to know each other, get a better sense of who they are. And sometimes that may have to do with experiential exercises where they might create identity cards, and describe how they would like to be seen, or having discussions, what is it that nobody knows about you that you think would be helpful for them to know, or what's something hard that you've really done. So having meaningful conversations with children, personal conversations, can lead them to be more attuned with one another, and pay more attention. And also there's some mindfulness exercises that I've been developing that are about, you know, like for example, with little kids, like experiencing being a pebble, right? But then afterwards, you notice that there's many pebbles in the room, and kind of widen your lens and your radar to notice how all of you pebbles together form a riverbed, and how important is that to be part of a community who forms something together and will be together for a whole time, and how can we take care of this community? So there's a lot of things that we can do that goes from the small individual to the group and the community and back and forth to cultivate that sense of belonging and caring for others.
Thank you, Marie Natalie. I almost got transported in that imagery. Next question is for Kat. How can we be better about connecting the gatekeepers to the resources that you talked about? And what resources do you think are most important for them?
I think part of the connecting gatekeepers to resources is that we have to accommodate the many ways in which gatekeepers can support people. So you might have gatekeepers who are a little bit older, who are maybe more comfortable with kind of the face-to-face and the debriefing, and they might have to have some resources that are sort of on hand or on the list to be able to provide someone. There are other gatekeepers who are maybe a little more technology savvy and may prefer something that they could just easily text or give to someone over the phone or over email or text in some capacity, right? So first of all, we're got to be working with the capacity of the gatekeepers. Second thing, some gatekeepers who might be a little less experienced might find a resource more useful than other gatekeepers who are a little more confident in their skills. So some gatekeepers might use an app, other gatekeepers may be able to connect someone to a resource, and then that connects someone rather to another group of people who have resources. Other things that happen with other things that happen with gatekeeping in terms of their knowledge, skills, or support. Sometimes there are individual programs within someone's particular region that are going to be more specific to that population. So for example, there's an organization, Insist Gatekeeper Program, and that has to do with Indigenous youth. So that might be one particular program that's in an area. So just be mindful about where you're looking at some gatekeeping programs, and make sure that they're going to be regional and really be able to support your population. And I think there was another one. What resources do I think are more important? Another one would be AIM Stay Strong is one more. And that's an app where there's a lot of engagement and there's a lot of rapport to help empower people in terms of their recovery. And that's one based on technology if people are a little more comfortable with that. And then there's another program called the Jacora Group that has a peer and professional debrief component, and some of the gatekeepers feel that is really good for support. So again, just keep in mind that when you're a gatekeeper, it's about giving out those support messages, but also staying in your own person and connecting with your own gatekeeping community to be able to provide that support for yourself so you can do the kind of delivery that you need.
Thank you, Kat, for those added details. The last question is for everyone to give a quick take on what language would you recommend using for youth in screenings? Whoever wants to go first.
Well, I'll start because this is, we created these suicide risk screening tools. I think you have to be very direct. I mean, some people don't agree with me, but I think being blunt and direct, and also remembering that screening is different than assessment. So if you're screening, I would not use a depression screen. For example, a lot of people, PHQ-9, Great Depression screen, not a good suicide risk screen. At least 13 studies show that it's insufficient to capture people at risk for suicide. So I would use very direct language to screen. And then when someone screens positive, then you can have more of a conversation. But for the screening, I would not dance around it. Don't use hurting instead of killing. I would just ask directly, are you thinking of killing yourself? And use a screening tool that has some evidence behind it.
Thank you, Lisa. Kat, Marie, Natalie?
Well, I would, as I said earlier, I would probably externalize problem. We'd get to know the child a little bit, and then I would ask if the despair or the overwhelm has ever made them think of killing themselves or ending their lives, and then I might ask if the despair has even given them ideas on how to do that and where they would find the tools to do that. And then I would, I'd proceed down the line of those important questions. But also, I would ask how they've been able to resist these impulses from the despair for so long. So I think those would be important.
Thank you, Marie, Natalie, and Kat.
I agree with what the rest of the panel has said. I tend to be pretty direct. So I would ask about what, have you had thoughts of suicide? But then I also will ask about, tell me about times when you maybe felt like committing suicide, or when you felt like you might do something to harm yourself. I start with that and then go into a little bit of, tell me a little bit about the feelings, the circumstance behind that. Sometimes those thoughts run through our head and they seem that they're incongruent with who we are. And sometimes they run through our head and it feels like that's where we really want to be. Tell me a little bit about when you had that thought. Was it a fleeting thought? Was it an impulse? Tell me a little bit about the tracking of it. When it happened in your brain, did it seem surprising or was it not surprising? And tell me a little bit more about that. So I look at the nature of the thought as well, because sometimes it does come from this experience of being trapped where it really is incongruent with who you are and the thought takes you by surprise. And there are other circumstances where the thought involves a lot more detail and planning. And I really want to know the difference between those two.
Thank you. Thank you, Kat. And thank you to all our panelists for their insightful contributions and to everyone who joined us today. Remember, if you or someone you know is struggling, resources are available and asking for help is a sign of strength. Please follow AAMFT for more resources and events like this. Please stay safe and take care of one another. Thank you for joining us.